my name is Leah Custer, and I'm going to be presenting on restraints and some other things surrounding restraints in the medical setting. So the attorney A, David Tamaleo, had this to say about restraints. They can protect patients or injure them. You could be sued for using them or for failing to. So Tamaleo is a traveling attorney that would travel around the country and hold seminars for nurses on legal issues such as restraints, and when to use them, when not to use them, different things like that. Although this quote he actually wrote in 1992, I believe it's super relevant today, and it still highlights the ambiguity that surround the use of restraints in the hospital setting. So restraints are kind of a double-edged sword, meaning that they do have some benefits, but also have many, many downsides as well. So one of the major benefits is that they do protect against extubation of the patient and also self-harm that the patient can cause themselves while sedated or in the hospital on event. But they do have very, very negative side effects, such as delirium, increased length of hospital stay, and also some psychological effects. And we're going to talk a little bit more about those. So one would think with those negative side effects that restraint use would be pretty rare to never when we try to avoid it as possible. But unfortunately, according to Solomon, in a 2018 study that he did, 33 to 57% of patients in this particular hospital that he looked at were put in restraints at least one time. And coupled with the quote that I overheard on the MICU at Altman, where I had my preceptorship, which the nurse stated that restraints are used on a majority of patients down here, as in the ICU. Those two factors kind of highlight the prevalence of used restraints, and coupled with the negative side effects that restraints do cause, I think there's a problem with the use of the frequency. So my question, my PICO question is, for nurses in an acute care setting, will education provided on poor outcomes from restraining patients decrease the overall use of restraints in the acute care setting? Basically, will education decrease the use of restraints in the acute care setting? First, I'm going to talk a little bit more about the background on the complications that restraints can cause, because I think it's important to get the big picture on how harmful restraints can be. So the first one I'm going to talk about is the increased prevalence of delirium as in relation to restraints. So in a study performed by Viveganathan et al., it was actually just published in 2019, so it's very, very recent. His team studied 5 different components that they thought might increase the chances of delirium. So those 5 components are listed, such as no sunlight exposure, isolation, no visible clock in the room for the patient being immobile, or the use of physical restraints. So out of those 5 components, 3 of them were shown to be statistically significant, and one of those 3 was physical restraints, was shown to increase the odds of delirium pretty significantly. Another study that I looked at, which was interesting, was by Pan et al., and their study showed that the duration of time that restraints were used and also the frequency that restraints were used also increased delirium. The specific results of the study showed that patients who were restrained greater than 6 days, their odds of having delirium or delirious symptoms would increase 26 times, and then if they were restrained 2 or more separate times during their stay, the delirium increased, or the chance of delirium increased by 4 times, which is pretty significant. In addition, Viveganathan et al. Also highlighted that delirium does increase the patient's length of stay in the hospital, and as I'm going to highlight in the next couple slides, restraints also increase patients' length of stay in the hospital. So if a patient is in restraints and then develops delirium, their length of stay is probably almost double as that of the normal patient, which is obviously not what we want. We want patients to be out of the hospital as quickly as possible. So the study on length of stay in the hospital as it relates to restraints was done by Kwok et al. It was a 2-year longitudinal study, and what they did is in the beginning of the study, they put new protocol into this hospital that hopefully would decrease the restraint use, and they were hoping that as the restraint use decreased, the length of stay in the hospital for the patients would decrease. And that is what they saw. Over the course of 2 years, as restraints were used less and less, the length of stay for the patients decreased, which is obviously what we want. Especially for cognitively impaired patients, their length of stay specifically decreased about a week, which is a long time. And again, we want people to get out of the hospital as quickly as possible. And it was really, really interesting to see the strong correlation between restraint use and length of stay. Lastly is the psychological harm that could be caused by using restraints. So this is kind of a subject that's still being discovered. There's a lot of, not a lot of studies on it, but the ones I could find kind of all had the same commonality of symptoms. So this specific study that I found was by Mower, Petty, and Mower, and they studied patients and up to 5 years after the patient was put in restraints. This patient was still having PTSD episodes, nightmares, and in some cases they had even just general distrust of medical personnel, which I feel like makes a lot of sense. And they also found in this study that if a person had previous traumatic experience, such as, like sexual abuse, or maybe even just getting in a car accident, or just any traumatic experience in their past, it actually decreased or doubled their chance of having symptoms like this after being restrained. So I thought that was very, very eye-opening as well. So we kind of talked about the complications for restraints, or that restraints can cause. So now I would like to talk about some reasons for restraints, because there are valid reasons for using restraints, such as what I mentioned previously, to prevent self-extubation. So when a patient self-extubates themselves, it can cause physical damage to their trachea and airway, and it also can cause respiratory distress if the reason they're intubated, which most likely the reason they're intubated is that they have respiratory distress. So if they're doing those things, we want to prevent that because it does cause them harm. However, the second most reason that Luck et al. Named in their study, the first was self-extubation was the reason to prevent that, that restraints were used. And the second most reason that nurses used restraints was as a precautionary measure. Which for me, that's when the ambiguity kind of starts to come in, because what is considered a precautionary measure, which we'll look into. So for me on the unit, one of the last days that I was in the unit, we had a patient where we were receiving a report from the night nurse, and the night nurse had told us, yes, the patient was combative during the night, tried to extubate themselves, so we put them in restraints. When we received a report, the patient was very calm, wasn't really moving, pretty immobile, and I'm thinking, okay, we don't really need restraints, but my nurse reordered them, and so when I asked, he just said, just to be safe. We just want to, have the restraints on, because if he is combative, we just want to be safe. Which on some level I understand that, but then on another level, if these side effects such as delirium, increased hospital stay, psychological effects, if they are so prevalent, shouldn't we use restraints as almost a last resort, or at least wait until they start to extubate themselves? Because we weren't that busy that morning. We could have paid attention and made sure the patient was not doing that. So that was very interesting. Also, for this patient in particular, we applied both mitts and soft restraints, which every time that I was rounding in the hospital during my shift, I would kind of make note on what type of restraints were on the patient. And I thought it was very interesting that about half the patients that were restrained at any one time had both of these restraints on. I feel like that is a little bit excessive, although I do not work on the floor. I don't know the protocol per se. I just thought that was very interesting that this was a practice that was done. To me, if you're restrained with just your wrist, there's no need to put mitts on your patient as well. I would argue that it actually violates the ethical principle of non-maleficence. As nurses, we are called to be beneficent, which means we help the patient and do good for the patient. But we also are called to be non-maleficent in the fact that we don't cause the patient further harm than is necessary. And I would say that doing this to a patient, putting them in one restraint or even two types of restraints that may be unnecessary, may be violating this principle of non-maleficence. So this quote, I believe, highlights that some of the nurses in the unit maybe don't understand that they might be violating this principle, and maybe are a little bit less educated on the impact restraints can have on the patients. So this quote is, "I don't know why nurses are so scared of using restraints. I'm not afraid to ask for them. Just slap them on there, and you don't have to worry about getting hit." On one level, I understand what the nurse is saying, because patients can get combative, and then the nurse's health is at risk. However, I believe that her comment of, "I don't know why nurses are so scared of using restraints," I think it's maybe she's just not educated, and the reason that people don't use restraints is because maybe they're aware of these side effects that can occur if restraints are used. So the question is, can gaps in knowledge, such as the nurse in the previous quote, be closed? So if you don't believe or don't know about restraints and the things they cause, can that gap of knowledge be closed via some information session or some seminar? And according to Kaya and Dogu in their study, if the answer to that question is yes, the knowledge gap can be closed. And so they actually found that it didn't really matter if you had a diploma, a degree, an associate's degree, a BSN degree, that it didn't matter what base level you had, that if you took classes, and for them it was a one-day seminar, that your knowledge level actually could increase and the gap could be closed. Furthermore, with a study by Eskandari, Abdullah, Zanel, and Wong in 2018, they used a pre- and post-test design where 249 nurses signed up for a one-day in-service, and that post-test after the in-service did show a statistically significant increase in knowledge of restraint use, when to use them, and different things like that. So the knowledge gap can be closed. So this kind of brings us back to my PICO question. So we know the knowledge can be gained, but will that education and will that knowledge actually decrease the overall use of restraints in the setting, in the clinical setting? So it's one thing to have the knowledge, but will we see a difference? So according to Smith et al., nurses in this particular hospital were required to sign up for one-day seminar, and the information covered included when to apply restraints, how to avoid applying them, possible poor health outcomes associated with them, anything surrounding restraints they basically covered in this one-day seminar. And 3 months later, the restraint use on the units was assessed, and restraint use was cut in half, and the length of time restraints were used was decreased 1 to 2 days total. And as we learned before, the length and the frequency that restraints are used increase the odds of delirium. So if these things are happening, then we're most likely seeing those decreased outcomes as well, which is what we want. So, can education decrease the overall use of restraints? The answer is yes. So my recommendation for the future in Altman Hospital is maybe to copy this and have a one-day seminar. That seems to be the kind of common theme in a lot of studies that I was looking at. So to have a one-day seminar where the nurses, especially on the floors that restraints are used commonly, attend, and that there's follow-up to see if there actually is difference on the unit. So in conclusion, restraints are a necessary evil that we sometimes need to use them in certain situations. Other situations they can be avoided. However, education can decrease the use of restraints, and the reduced use of restraints does increase patient or positive patient outcomes. And positive patient outcomes are what we strive for as nurses in the nursing profession. So these are my references, and I'll take any questions. Sarah.
Okay, so we all know that restraints come with a lot of documentation involved with them. If there's so many patients in these restraints, did you notice any loss and connect with the appropriate documentation at all?
Do you mean, just to clarify, do you mean that since there were so many people in restraints, the documentation was a little lax, or they didn't follow protocol, or what do you mean by?
Correct. Did they keep up with all the necessary documentation?
Okay. So Altman actually implemented Code Rose very recently, which is a group specifically tasked with reviewing documentation of restraints. And so the general feel, that's actually what got me interested in restraints in the first place, was the general feel is that Code Rose is kind of a nuisance, which on one level I can agree, because they did up the documentation that the nurses have to do, and if you have 2 patients that are in restraints, then you kind of get the sticky areas. However, for the most part, I think nurses follow the documentation. There wasn't any instances that I could find that nurses would put the restraints on and not document. But I also wasn't monitoring every single nurse, so I'm not sure. But I know my nurse would get calls a lot for documentation he did days ago about restraints that he needed to go fix, because Code Rose was just then reviewing it. So, yeah, there wasn't lax documentation, but it definitely was not appreciated that it was that stringent.
Now, correct me if I'm wrong, that Code Rose was put in place by JACO?
It was put in place in response to JACO's report that the documentation was a little not up to snuff, I guess. They didn't get penalized for it, but it was one of the recommendations that JACO made, so then Altman implemented Code Rose.
Do you feel that that also was possibly a response in the fact of their finding being that so many patients were in restraints, and in hopes that restraints, because of upping documentation, that maybe restraint use would also go down?
I did not get any concrete evidence that was the case, but in my observation, I would say that's probably what was going on, because I mean, in any given day when I was rounding on the unit, we had 16 patients, and 8 of them would be in restraints, and some of them in double restraints. So I'm wondering if that maybe was the underlying goal, but I don't think that actually made a difference.
Okay.
I'm curious if any in your research that you saw any alternatives to restraint use. I understand you're working with education, but did you see anything regarding the use of a live sitter or?
Yes, and that's actually, I was going to include this in the PowerPoint. I did talk about it in my paper, but sitters was brought up. I did ask my nurse about why don't we have sitters, and he was saying they do have them on the med-surg floors, but they barely can afford having them there, because you're essentially just paying someone to sit in the room and really do nothing else, so they're kind of a drain on the budget. So he said they've been trying to get sitters in the ICUs, but it's just so expensive that it's in like very, very rare cases. So sitters is another option. There also was tasking the family with sitting in there and preventing the patient from extubating themselves. Like the problem with that would be the patient's not really informed on like maybe some actions that would be precluding extubation. They might just be like, the patient's fine, and all of a sudden they like reach up and like rip their tube out. So sitters was an option, family was an option, and another one was like chemical, like pharmacologic sedation, which is obviously you want to try to avoid. So yeah, there were alternatives. It just is difficult because your patient, you never know when they're going to extubate themselves, typically.
Correct. I was just curious to with the reasons, like the long-term effects of the restraints. It seems like a live sitter would kind of not only prevent the restraint, but also prevent some of the effects of delirium, confusion, having a live person to communicate with.
Mm-hmm. Oh yeah, definitely. I think the studies, I found like 2 or 3 on it, and most of it was just that it was